come in. And this is going to be important because what I'm going to tell you in a moment is going to really make some sense. And your cribriform plate right there, okay? Your cribriform plate. Didn't Mr. Schultz talk about that when he did the eyes? I had him do that, and he showed you that. All right, here we go. Now, let's do we're going to go, and we're going to feel the back of each other's neck. Number one, since C1 is called, it has to hold up the head. What in Greek mythology? Atlas, right? So C1 is called the atlas because it bears the weight of the head. The problem with C1 is if you fracture it, it will not, most patients, 9 out of 10 will feel no pain. So they'll be walking around. Now, how do I know they've possibly fractured it? Well, it's an easy bone to fracture. It's a soft bone, okay? And here's how you do it. You hit anyone downward pressure, or somebody comes up and hits the top of their car, they get a laceration, they get what's called a blood spot. All right, are you with me? Yes, any laceration at the top of the head, I'm concerned C1 has been fractured. Are you with me? Any laceration of the head, I'm worried about C. Compression, it'll fracture easily. Are you with me?
Yes, sir.
All right, now what patients will do, if Atlas isn't there to hold up the world, if C1's not there to hold it up, every walk, every step you take is going to push your spinal cord up into your brain. Your brain's the heaviest part. It'll start to settle down. Your brain will swell within 24 to 36 hours. If you're not dead, you most likely will be dead. You will present with the ER with blurred vision, nausea, vomiting, disorientation, and that is because you are literally dying in front of them. We cannot miss this. If somebody says, I have no neck pain, and they say, but I've got a laceration, or I've hit the top of my car, or somebody bludgeoned me on the top, and they've got a laceration, then you C-spine them, they have a C1 fracture until proven otherwise. Are you with me?
Yes, sir.
That's how we can save a life. C2 is your rotational. It's called your axis. Your axis. So again, those of you who took anatomy and physiology, I want you to be here with me now. Help me out. So C1 is atlas, C2 is axis. It's only important because it turns. It very rarely is fractured. Very rarely. But it can be. All right? So it's a little stronger than C1, by the way. C2, C3, C4. Now, when you get to C3, C4, this is where if you get a fracture and you fracture the cervical spine right here, or right here, what happens is the bone fragments cut into the cord. If they cut the cord off, they slice into the cord at this level, patients will be conscious, they can hear you, they can see you, and their eyes will move, but they're not breathing because it's cut. All breathing and respiratory, it's cut the signal, so there's no breathing. They're literally suffocating in their eyes. They're blinking wildly, but they can't speak either. Are you with me?
Yes, sir.
So that's a C4 fracture. C5. C5 is where you put the hangman's knot. We do 8 ropes. You put it here in the Wild West. And what happened is when people would be hung, they figured out what was your body size, what kind of drop you needed. And when they broke your neck at C5, what they did was you were not dead. They broke your neck, which caused you to go unconscious, which then they left you up there to strangle for a few more minutes, and then you were good and dead. Then they brought a doctor up and said he's dead. It wasn't that you were dead. The fracture in your neck did not kill you. It was the subsequent swelling, and you were unconscious and you weren't breathing during that time. That's what took you out. Does that make sense? Yes, ma'am.
That goes for any time you break your neck?
Yeah, people who break their neck doesn't mean that they're going to die immediately.
My mom's fiance died on a motorcycle and he broke his neck, and they told her that he died instantly from that.
Well, it can't if the fracture was so great that I've seen people move their skulls off of their spinal. Then yes, that would do it. Okay? You with me?
Yeah.
That would be. But for the most part, just by hanging, you should not. It'll snap your neck, drop you in unconscious, your cord will swell, your brain swells, and then you go out within a few minutes or so.
Okay.
But it's not. I don't want people to think. Now, is it true that if I miscalculate, this is a 300-pound man, and I get an extra long drop, I could literally rip his head from his body, and that's happened before. You understand? That's why there's a science to that. So, yes, you could do that. And that happened to a bad bandit. He was waiting for he had killed like 20 people. I forgot, it was Black Bart or something. And what they did was they put him in jail, and he ate every day 3 squares a day. He was inactive. And when they originally measured him was when he went into jail. And so they were waiting, and he had appeals and stuff. By 8.5 months later, they finally ran out of appeals. They took him up to the gallows. He actually put on an extra 100 pounds. So when he got there, it snapped and ripped his neck, and it was a gruesome sight, they said. Body hit the ground, head was still dangling. Not cool, all right? But we're not here to talk about it. You get the idea. Okay.
Yes, sir.
So, C1, C2. C1 is atlas. C2 is axis. C4 is no respiratory. So we have to breathe for him. Yes, you have to breathe. The patient can't speak or breathe. That's really, but if their eyes are flashing, you know what's going on. C5, the hangman's knot. C6, C7. C7 is the one that's the hardest because it's buried. So I want you to feel C7. Reach into somebody's neck and ask them if you can feel C7. It's that bump that's kind of right at where it articulates in your thoracic cavity, right? The back. And that it's hard for docs to get a good picture of it because now it goes into muscle. Does that make sense? So they may keep them on the board a little bit longer, all right? So now take just 10 seconds and reach over and feel somebody's C7. It's that little bump. Have them pull their neck down. It'll hunch over. There you go. Okay? Okay, you got it? Okay, now, stay right there. Okay, yes it is. Okay, stop right there. Okay, Drake, would you hit the light for just a second, and then we're going to turn it right back on. Okay, I want to see what we've covered so far. All right, so we did that. We did the frontal and the anterior. We actually went above that. All right, next thing. Hold on. We did directional terms. I'm going to talk about this in a second. We talked about anterior versus posterior. We talked about midline. And toward the midline is going to the medial aspect. Going away from the midline is going to the lateral. All right? We also talked about, well, we didn't talk about it. Let me do this. Is we have distal, distance away from the heart, and proximal, close to the heart. You're proximal and distal. So now this becomes, it's going to take a little practice for us. I don't think you're going to get it down the first time. Maybe you will. Squad leaders and assistant squad leaders help everyone. If I have an injury that's right here, a laceration, and I have to describe to the doctor, first of all, Leonardo da Vinci devised this. The man and woman, this is the anatomy. This is the anterior portion. When you slap somebody, this is when you backhand somebody, right? Because it's toward the posterior. This is how your body is. This is called the anatomy of man. So right here, you with me?
Yes,
everything forward is anterior, everything back is posterior. Okay, so I will tell the doctor that I've got a 3-inch laceration that is on the anterior aspect of the right arm, and it is 2 centimeters distal, distance away from the heart, right? And now I have to tell him where? From the antecubital fossa. Now he or she will immediately know that it's 2 fingers down, it's a 3-inch laceration on the anterior aspect, and it's distal. If it were proximal, then I would have to say it was up 2 inches, proximal to the AC. Does that make sense? Yes. Because I'm using the AC as my anchor, my geographical landmark, and if I go above it, I'm going proximal. If I go below it, I'm going distal. Does that make sense? Yes. Okay, good, very good. All right, well, hold on, we'll do it again. What's the matter? What?
How would you describe this?
Okay, that is going to be a big one. I would say that this injury is on the anterior aspect of the right arm. It's about 3 inches proximal of the antecubital fossa, but continues on another 4 to 5 inches distal of the antecubital fossa, and it runs to the proximal aspect. So that's what I would tell the doctor, and they would know that it was an injury that was here, and they would be able to kind of map it out. Gives them an idea. Okay, now this is really important. I didn't do this, but let's do it real quick. Whenever I bring my arm to it, that's called adduction, because ADD, listen to that, adduction, ADD, I'm adding it. Oh, I can't do this. I'm adding it. See, it's coming from here, and I'm adding it to my body. That's adduction. Abduction is to take away. So if I take my friend here, Sherman, and I grab him, and I say, you're mine, and I put a gun to his head, what am I doing? And I'm taking him out of the classroom. I'm abducting him. I'm taking away. So whenever you go this way, you're abducting. Whenever you're adding, you're adducting. Are you with me? ADD. Okay, good. Thank you, Sherman. Here we go. Let's move on. Let's move this quickly. I'm trying to... something worked. Sir, go ahead and hit me a little... go to me the next one. Maybe it's just the batteries going down. Okay. All right. This is important. Okay. Need a boy and a girl. Okay, I'll use you as my boy, okay? Maybe you're kind of shy. I've already used you. Let me use you as my girl. Okay, here we go. Now I'm going to tell you because it's really important. Here we go. First of all, I want you to stand up here, take off your jacket if you would, please. Come on, pull back here. Let's do this real quickly. Okay? Because you got to read this. You got to study it. I really can't help you with the studying part. Okay, spread a little bit this way. There you go. Okay, now watch this very carefully. Where's your belly button? Okay, so his belly button is right there.
That's
all right,
really
now listen. hold the back of your patient. Whenever I'm doing something, I hold the back, because when I palpate, it gives some stability to it when the patient's sitting up. So I say, and hold the back means not the butt, okay? It means the back, okay, where the curve is. Now what I do is I find the umbilicus here, and I know that this is my quadrant. This is his lower quadrant, this is his lower quadrant, upper quadrant, upper quadrant. Are you with me? Yes, if I poke and say, does that hurt? Yes, it does. I'm poking. So we don't poke. What I do is I take my hand, again, where's your belly button?
Right there, you're touching it.
Oh, okay, there you go, okay. Oh, I'm getting to know you. So watch this. I'm going to roll. Do you see how I roll my hand? Roll in it. If I roll and he says, no, that doesn't hurt, and then I roll off and he goes, ah! That's called rebound tenderness. That means there's blood under there. If there's blood under there, I push the blood back, but when it comes forward again, it interacts with the muscles in there, and it inflames them, and it causes pain. Rebound tenderness. Are you with me?
Yes, sir.
Okay? So, if I push and he's got pain, and I just push in with pain, that means the blood is now engorged the vessels where they won't push back. They're going to stay there, so there's going to be pain in and pain out. All right? One's rebound tenderness. It's rebounding tender. But here it's going to be tender the whole way. Are you with me?
Yes, sir.
Okay? Now up here, this is a dangerous quadrant. This will kill him because his spleen's here. All right? Yeah, there's the stomach, and if his stomach contents spill or his poop or pee spilled in there, he'd get peritonitis, but that'll kill him in 3 days. But what will kill him within just a few minutes is a ruptured spleen. All right? He's in a car wreck and he's ruptured his spleen. He's been hit with trauma. He's ruptured his spleen. Somebody stabbed him or shot him. That's going to do it. So what I'm going to do is if he's got pain in that area, it's a spleen until proven otherwise. Are you with me?
Yes, sir.
Over here is liver and solid organs. It'll kill him, but it's more infection, all right? He will bleed, but he probably could last for a couple hours. But still, I note that. Down here, it's going to be poop or pee, mostly poop, and it's going to be peritonitis. So he's ruptured the colon or something down there, okay? His intestines have ruptured, which is put out food or something like that. So if I feel that, I know he's got a few hours. I could probably have maybe a few days. Here, man, oh man. If he has pain in that area, it's like the spleen. These are the two deadly areas. Upper left and lower right. Oh, did I go too low? Okay, sorry. I didn't know you. All right, so right in here. Well, then that's going to tell you that, you know what, that is appendicitis or the appendix. And I just had a friend. Oh, dear Lord, I'm glad. Today, I need 2 cards. 2 cards. One is Chris Lieberdorf, Northern California. His father is dying, and he is a author of the books. He's a great guy. He comes down to our college at least once a year. He's a wonderful guy. Students love him. His father's dying. We will write cards. And also I have a friend that's in Pittsburgh. He is his wife's the executive director, and he just had appendicitis and was taken into emergency surgery. But he's doing fine now. See, that's what I'm telling you. We got to know those things. Yes, ma'am.
Did you hear anything about the Paige Miles girl?
Yeah. See where she was removed from the ventilator. So it was important for us when you wrote those cards to support the family. The family was deeply touched by all the cards that they received. So while she was still alive and with us, we were able to support one of our fellow EMT students. More importantly now, we've helped ease a little bit of the pain for the family, but they've decided to take her off the life support. So these are the sad things that we live with. Life is, every one of you will meet your maker. There's 2 things you're not getting away from, and that's taxes and death, all right? So it's nice to help each other through those processes. Now, if a guy has this stuff, it's mostly generally going to be trauma, or, you know what, he's ruptured a bowel, or he's got, he's done something inside. So any abdominal pain is an emergency. Now let's turn to our female. All right, where's your belly button? Okay, now see look how his is way up here and yours is way down here, all right? The pants, there you go. I knew you guys were mentioning the girls hate the pants. Okay, so here it is, the belly button, right here, right? Okay, there it is. Oh, that's an innie, isn't it?
No,
yeah.
it's a piercing.
Oh, okay, all right, okay, it is, okay, very good. Now I'm curious. I see that. No, okay, so it's right here. So hand goes still to the back right here, okay?
He's cheating on
and
me.
Then, and then what we're going to do is these are the quadrants right here, right here, and right here. Now again, I've centered off there. I make 4 quadrants. So again, carefully and professionally, watch my hands. I'm right here, okay? And I push in, and then I'll let out. So I kind of roll just a little bit. And I roll right over here. But this is the left side, so what am I worried about? Spleen. Okay, then I come down here. Now, again, find her belly button, because I want to go low. She never should be on the pubic bone. Right here, what am I feeling? Appendix, the appendix. But what if I have something that's bulging out, or I see that she's got a heartbeat? You see, I want to visualize this. It's a pulsating mass. Do not push on it. Because if I push on a pulsating mass, it means that she's ballooning out. And I'll push on it, I will for sure rupture it. And now she'll go unconscious. Are you with me? Are you with me? Okay? And then I'm going to come over here. What if she has pain here? If I push in and no pain, but I let out, ah! Rebound tenderness. What could be here, though, that's causing her pain? Yeah, her colon, her intestines, but that will kill her down the road. Are you with me so far?
Yes, sir.
Okay, now let me tell you something unique about women. Women are Ferraris. Now, I'm not dissing us at all, but we're Volkswagens. Okay, are you with me? We got plumbing and everything, but we don't have as much intricate stuff as women do. Women just have sexier stuff. Now, the thing that I'm worried about is if she is complaining of abdominal pain, what does she have until proven otherwise?
Ectopic pregnancy.
Yes. I understand that every time I say, ma'am, is there any chance you can be pregnant? No. Especially if other people are at, no. That always, no one in this country sleeps. It's amazing how all of you are standing here, all right? No one's sleeping with anyone. But you know what people do? They're not going to tell you the truth. So the thing is that I say, ma'am, it's important that I know, because with your abdominal pain, this could be an ectopic pregnancy, which happens in 1 to 250 pregnancies, and it can kill you. And then, you know, if she still says no, I'm still going to assume it is and treat it as if, I'll end the conversation, but I will treat it as if she is having what?
Ectopic
An
pregnancy.
ectopic pregnancy. Are you with me? Because that will kill her immediately. Anything else could be. Doesn't mean she has an ectopic pregnancy, but it is, until proven otherwise, she has an ectopic pregnancy. Are you with me?
Yes, sir.
Okay. And again, women are just, again, you just have to, you know, I want you to feel very professional. You see, guys don't care when you go pushing on. They're okay with it, you know, all right? But when you do girls, it's a little sensitive through there, and they're also going to tell you. Now, the anatomy, first thing I like to always feel is her hips. You feel her hips right here? Mm-hmm. Because when I break up her quadrants, then I know that I go over 3 fingers, and there's where her appendix is right there. That's where I get a good feel. Does that make sense? That didn't sound good at all. Forgive me. Yeah, you know when her pelvic wing is here, look at where her umbilicus is. Her belly button's right here. Huh?
Same for males, too?
Yeah, well, yeah, but males, you know what? It's funny because, hold on just a second. Let's go boom, boom, and I quadrant it down here. The thing about the pelvic on women are easier to feel. You have more fat on you, more adipose, muscle. You understand? So your muscle and fat is a little heavier. Women have these incredible wings that when they wear their pants, now guys will do it if they really get a 6 or 8 pack. Have you seen that? Where then you can start to see, now ma'am, that's not good. You start to see that. And that's, you know, it's one of the problems I have when I wear, you know, short sleeves. It's really good. Okay? I'm just not seeing it right now. But women have these pointed, and it just helps me anatomically. I use all those structures to be able to find things a lot easier. Okay? Women also have a little less body mass. Even though their hips are a little bit wider, they're more pairs, and gentlemen are more apples, but women are more pairs. But where they're going to put their weight is on the side and the saddlebags and through their butt. But through the front here, it gives me a lot of chance to kind of really get in there and see what's going on. Are you with me?
Yes, sir.
Okay, so we're cool. So let's give them some love. Thanks, guys. Let's click through some more. Oh, it does. Thank you. Okay, let's go through. Well, it's not doing. Now it is. All right. Now, there we go. Now, lay down, sir. Lay down, sir. Right there. This is supine. Supine. This is supine. Okay? Turn over. This is what's called prone. And any test question where a patient starts prone, you've got to turn them over to, turn to supine. Turn to supine. Let's go. Roll over, done. Okay, this is supine before you can treat airway. Are you with me so far? Yes, now, come up 3/4 way. Stop. This is called a Fowler's position, but it's called a semi-Fowler's. This is the position that I put patients in that are having heart attacks, chest pain. Are you with me? Because it reduces the workload on the heart by 15%. Come sit all the way up. This is the position, it's called a full Fowler's. A Fowler's position where I put them up when they're having shortness of breath. Are you with me? Yes, all right? Lay back down 3/4. This is a position I would put them in if they're nauseated or not feeling well. Boop, sit up. All right? If they're dizzy, I'd put them in that.
Working my abs.
There you're working the abs. There you go. And if they're sitting full up in the Fowler's, that's what you sit in every day. Okay? Are you with me?
Yes,
so
sir.
let's do it again. Lay down. Supine. All patients are pretty much transported this way, unless they have chest pain. Put them up in semi-Fowler's. Okay, and now they're nauseated, they're vomiting. Put them up into full Fowler's. Okay, go back down, supine. They're unconscious, all right? Not feeling well at all. But now they're having abdominal pain. Sit up into Fowler's position. All the way, full Fowler's. That's what I would do. Or he's having shortness of breath. He's in full Fowler's. Are you with me?
Yes,
oh,
sir.
he's a little dizzy now. Put him back into semi-Fowler's. Are you with me?
Yes,
okay, now lay him down supine. Turn him over. He's now prone. Are you with me?
Yes, sir.
Okay, there's no reason for this. The only time I'll do this if he's got something stuck in him. A knife or something, an arrow's gone through him, right? Okay? Something is here. Trust me. Then I may have to transport him that way because I have no other way. The only time, well, we never remove anything unless it's compromising the airway. Well, that's not an airway compromise. Yes. I mean, I've had a guy that was on a motorcycle that got right up through his anus all the way out. He got an iron rod, you know those fences? And we had to cut with our Hearst tools. And I had to transport him with it sticking here, up through his butt, up through the area there. Yeah, and it bent. You know? Yeah, that's not good. Okay, so we got that one, right? Okay, now turn to your side. He's now pregnant. Okay? So, pregnant women must be transported this way. Matter of fact, pregnant women, any pregnant women that anyone had children in here? Okay, you guys give me the amen. Okay, good, right? So when you're pregnant, you felt the weight of the child. You couldn't lay flat because the weight of the child will press on your vena cava, which will then keep blood coming to your brain, which then, and I'm going to say something, and I'm not trying to be funny, this is medical, we are medical people. The number one call that I had for pregnant women, you'd think, this is amazing to me, was because the husband and the wife were having sex in the missionary position. Pregnant women should never be in a missionary position because as she started to climax, it requires more blood, more things are moving in different areas, and she passed out. Why did the body have her pass out? It was conserving the blood for oxygenation, all right? And so, yes, you're going to go on calls that are embarrassing, but you must be a professional. So I get there, oh, I killed her, what's going on? Well, she's naked on the bed. I kind of figured something. I said, sir, it's okay, but listen, let me help me turn her to the side. My crew will help turn her to the side. And then still, you have to wait a few minutes. I'm checking her area. Sir, were you engaging in sexual activity? That's what I always say. And he goes, yes,